presentation from Dr. Pedram Razavi from Memorial Sloan Kettering Cancer Center. And he's going to talk to us about challenges in early detection, and in particular, challenges of using circulating tumor DNA in screening for cancer.
So thank you so much, the organizing committee, Dr. Cristofanelli, Dr. Turner, for inviting me. It's my pleasure to talk about challenges and also the opportunities in early detection in early stage breast cancer. I will be covering mostly screening and MRD, and will focus on ctDNA. These are my disclosures. So a very brief overview of biology of cell-free DNA and circulating tumor DNA, ctDNA. It's a very dynamic process. It's constantly released from the normal cells and also cancer cells. The main process is through apoptosis, but other things that result in cancer cell also release and sheds the ctDNA. It clears very effectively and very quickly through elimination by the circulating nucleases, through liver macrophages and kidney, and the half-life has been shown to be around minutes to hours. So this is a constant release and constant clearance. So ctDNA shedding in normal condition and cell-free DNA shedding in normal condition depends on many factors. Proliferation and apoptosis is one of the main ones, and the site of the tissue is another one. And it's been constantly shown that the hematopoietic stem cells, these are the fastest growing, some of the fastest growing cells in the body, are the main source of cell-free DNA in normal condition. Anything that results in cell injury, inflammation, autoimmune conditions, cytotoxic therapy can increase this amount of normal cell-free DNA, and also increase a significant increase in cell-free DNA after if the clearance is impaired. In cancer setting, ctDNA fraction, or the amount of cell-free DNA that comes from the tumor, varies very extensively by histology, stage, tumor subtype, disease site, and also some important features such as tumor biology. And more importantly, the disease burden seems to be a major factor affecting the amount of ctDNA in the blood. We showed it in the metastatic disease. Also, multiple studies in early stage showed that the size of the primary tumor actually is associated very directly with the amount of ctDNA shed in the blood. So this is a very robust biomarker. We've been using it widely in metastatic setting. We are using ctDNA to identify actionable alterations, monitor disease response, look at, monitor clonal evolution, identify mechanisms of resistance, dynamic changes in the on therapy. Many of these we heard about in the earlier talk and also in the morning. But what about in early stage? The challenge in early stage is that the amount of ctDNA, often in even metastatic disease, is very slow. In early stage, it's extremely low. Often, there is less than one genomic copy of a cancer cell in the whole tube of blood, meaning that we don't even have one full copy of the DNA of the tumor in the blood. And then we need to devise new technologies to be able to identify these tumor-derived variants and tumor-derived fragments at extremely low levels. So I'm just going to go through some of the technology. Imagine that this iceberg is the mutational profile of the tumor. So the part above the water are the clonal mutations. These are the mutations that every single cancer cell has them. And then below the water are the subclonal mutations. And the deeper we go, the more subclonal, the more rare the variant. And we've been devising very small panels of genes, and we've been sequencing them very deeply, and also devise external barcoding systems called UMI, unique molecular identifiers, or in silico error corrections, to decrease the amount of noise and improve the sensitivity and the specificity of the assays. And it's been proven to be very effective. However, the broader application of ctDNA, both in metastatic and early stage setting, often requires broader look at the genome of the patient, mainly to cover inter and intra-patient heterogeneity of the tumor. That is a fact in breast cancer. So multiple of these assays have been developed, and the data is showing that such assays are very effective in metastatic setting to identify tumor mutational burden, MSI, mutational signatures. We can monitor clonal evolution and mechanisms of resistance through these mechanisms. But for de novo detection of each alteration, the sensitivity of the assays are limited. The best that the assays that can do so far is around 0.1%, slightly lower, depends on the assay. And the problem with the early stage is that we don't know the mutational profile of the tumor, and if we use this for de novo mutation calling, it can be completely off frame. So we look at the different site where the tumor doesn't have any significant mutation, and that will affect the performance of this type of assay. Another feature that it is important, and we showed it and others have shown as well, is that the clonal hematopoiesis is a universal phenomenon, happens almost in every single individual, normal, non-cancer person, and also cancer patients. In metastatic conditions, more than 50% of the mutations that are identified in a cell-free DNA are actually coming from clonal hematopoiesis, not coming from the tumor. And this is very important because some of these mutations affecting the canonical CH variants, and some of them actually are known tumor cancer-related variants, like affecting P53, and even some actionable alterations. And also there are passenger alterations that result in somatic alterations in the cell-free DNA, and this can be a significant biological noise if we would like to go for de novo detection. When we do match normal sequencing from the buffy coat from the white cells, we cancel some of these, but we've shown that some of these are actually at extremely low levels, so when we start using extremely sensitive ctDNA assays, we may actually miss it. So because of all these reasons, I think that these type of assays, even the very wide ones, are not suitable for screening as standalone tests, and also not suitable for MRD detection in most of the conditions. So there are some cancers, extremely hypermutated cancers, you can use such assays for MRD detection, but for most of the breast cancers, that's not the case. So what are the approaches? One of the approaches is cell-free DNA methylation and methylomics. I will cover that as through this talk. Another approach is whole genome sequencing to identify the fragment sizes of this ctDNA and cell-free DNA and look at the patterns of the fragments, something that we would like to call fragmentomics in the cell-free DNA field. And another one is combination of approaches, methylation plus targeted panel, combined protein biomarkers with cell-free DNA analysis, combined cell-free DNA analysis with imaging, and also the one that is now being used very often in MRD setting is the tumor-informed or bespoke assays. So I will covering this screening first. So one of the main types of assays that are being developed uses the methylation patterns. So these CpG sites are very unique. The methylation patterns are unique to the site, to the tumor tissue, and also to the tissue that it comes from. And putting all of these together and through the analysis of thousands of cancer patients and controls, GRAIL has been able to identify significant signatures that not only can say that this tube has methylation patterns that comes from the tumor, but also can, with good accuracy, predict the type of cancer as well. They validated this approach in a large series called CCGA, and the data overall was good. A lot of the cancers have been they've been able to identify multiple cancers, but for breast cancer, it was actually, the performance was not acceptable. For stage 1 breast cancer, less than 5% of the patients actually have been able to identify using this approach, and then the approach had significant improvement when we look at stage 3 and stage 4 breast cancers. And then more importantly in this study, when they looked at detected breast cancers, actually none of them have been identified by this approach. So there is something with the tissue, breast tissue, even some of the large breast cancers seems like to have not to shed much of a ctDNA in the bloodstream. Now this approach is being evaluated in a pan-cancer setting in multiple large clinical trials and clinical studies. STRIVE is one of them that is relevant to what we do, so it's combined with screening mammograms. With the approach, they would like to include 100,000 women in the study. I think that it is complete and it's in the follow-up section. And we will see if this approach can actually improve the efficacy and performance of the mammograms. And also multiple other studies looking at the performance of this type of assays for general population screening in a pan-cancer setting. Another approach comes from another important part of the cell-free DNA biology, and that's the cell-free DNA is actually attached to the nucleosome, and the nucleases chop the cell-free DNA around the nucleosome. So when the chromatin is slightly open or there is more expression, especially in cancer cells, seems like the H1 linker is lost, and the loss of H1 linker results in significantly smaller fragment sizes of the cell-free DNA coming from the tumor. Very consistently within patients and across the cancer patients compared to the controls, it's been shown that the fragments that are coming from the cell-free DNA from the tumor has a size of around 146 base pairs, and in non-cancer fragments are around 166. More importantly, when the chromatin is completely open to express the DNA, that part is not associated with any nucleosome, and then the nucleases will chop that part of the DNA to very small fragments. And then when we do whole genome sequencing and put together the patterns of these cell-free DNA sizes and the fragment sizes together, we can actually get a sense of expression profile of the tumor. And this is also very unique to the cancer and also to the sites. So another approach that is being developed in this space is an approach called Delphi, looking at the cell-free DNA fragmentation patterns. And they developed this using whole genome assay, and then develop machine learning algorithms to predict the type of cancer. Preliminary data has been reported and looks like to be promising. The larger study is now being done in lung cancer in association with screening low-dose CT scan, and we will see how this data looks like and if there's going to be any evidence that this type of approach can be useful in breast cancer. Another approach in screening is combining it with proteomics and the proteins. This is an approach that the colleagues at Hopkins pushed forward. The idea was to go for a very small panel of genes to decrease the amount of noise coming from the sequencing and also from the biological noise, clonal hematopoiesis, so on and so forth, and then add another type of biomarkers, proteomics. And then early data showed that they can actually identify the tumors with this approach. And then the updated data is showing that actually this is usable in the larger setting for identify cancer. This is based on the DETECT-A study, but I would like to pay attention to the breast cancer. Most of the breast cancers that have been identified in this study actually were found through the standard of care screening and not this type of approach, consistent with the other studies. That seems like the primary breast cancer doesn't shed much of a cell-free DNA. So, in conclusion, the current multi-cancer early detection ctDNA assays have relatively low sensitivity for breast cancer and cannot replace standard screening modalities. Pending data to determine their utility in improving breast cancer screening in combination with standard of care imaging. And also there is potential benefit or maybe utility for non-breast cancer screening. These assays have shown some potentials in finding non-cancers. So we can look at the patients who are high risk of second cancers, germline carriers, childhood cancer survivors, so on and so forth, and design studies to look at this. So what about MRD? There is much more advancement in this space. So most of the approaches are using sequencing based on the primary tumor profile. So we sequence the primary tumor and develop an assay. It can be digital PCR, can be targeted sequencing, whole genome sequencing, or structural variants to identify evidence of ctDNA in the blood. And also there are approaches being developed that are tumor independent, such as the ones that I just mentioned, fragmentomics, methylation, so on and so forth. But there is not much data clinically at this point on this part. So I will focus mainly on the bespoke assays. This is one of the very early studies that was done by Dr. Turner and his group. And this is the updated data. They looked at high-risk patients who received neoadjuvant chemotherapy. They looked at post-op ctDNA, and then the assay was based on a digital PCR. 1 to 2 mutations were included in that digital PCR assay. And then you can see that the assay showed, especially when it was serially tested, it showed that it can identify the evidence of MRD in the patients, and ctDNA positivity was very strongly associated with risk of recurrence, something that we also saw this morning. But this type of assay seems to have slightly limited sensitivity. The problem is that when you look at one mutation, and we look at less than 1 copy of ctDNA in the tube, there is just by chance, stochastically, that DNA may not exist in that tube of blood or may not be captured. So increasing the number of mutations very significantly improved the sensitivity of the assay. So now the approaches are looking at increasing the number of variants, tumor-derived variants, and also finding the sweet spot between the sensitivity and also specificity by decreasing the amount of noise related to the assay. This is one of the typical approaches. Tumor tissue will be sequenced, whole exome or whole genome sequencing, tumor-derived variants, confident tumor-derived variants are identified, and a patient-specific panel is designed. And these mutations are selected based on the clonality of the mutations, how good that part of the genome can be captured or amplified, or how error-prone is that part of the genome, so on and so forth. And then after that, ctDNA will be sequenced using this patient-specific panel to alter deeply to identify these mutations. And the benefit of this is that there is significantly less sequencing noise because we just look at the very small part of the genome. And also there is not much chance for CH-related false positivities here. It is possible, but the chances are much smaller. And this kind of approaches have been shown to improve the detection threshold very significantly. So this is one of the studies based on up to 16 mutations published by Dr. Coombs, and then we see that this study actually included both ER positive as well as HER2 positive and triple negative patients, that patients who received neoadjuvant and adjuvant, and you see that replicates the type of data that Dr. Turner showed, but slightly better sensitivity in this type of approach, and we see that the patients who had ctDNA positivity, almost 100% of them had recurrence, and the patients who were ctDNA negative were not. This same type of approach, ctDNA analysis, was applied to I-SPY 2, and this is important data because it shows that we can actually identify evidence of ctDNA in the neoadjuvant setting and monitor the response to neoadjuvant therapy. There was association between baseline ctDNA and the type of cancer, something that we expect. The more aggressive tumors are more likely to be found in the blood. But also, I would like to pay attention to these parts of the graph, that some patients cleared the ctDNA after only 3 weeks of Taxol. Some of the patients required more Taxol to clear the ctDNA. Some of them cleared the ctDNA after they received AC, and some of them were completely resistant throughout the therapy, providing an opportunity to go early and identify these resistant tumors earlier on and escalate the therapy for them. An important part of the data also was that the ctDNA detectability at baseline was actually very significantly associated with risk of recurrence, meaning that, again, based on the methylation data and so on and so forth, we know that primary breast tumor doesn't shed much of a ctDNA. So some of this ctDNA actually coming from the micrometastatic sites that we are capturing here, and that's probably why it's associated with outcome. And when they looked at the last cell-free DNA collection in this group, they didn't have anything post-op or in the adjuvant setting. You see that when the data is combined with PathCR, the prediction and prognostic efficacy of it improves very significantly. The patients who had a PathCR and they were ctDNA negative did extremely well, and the patients who actually were ctDNA positive and did not have a PathCR did very poorly, helping us identify the patients that are extremely high risk. So what about increasing the numbers, going to the hundreds? So this is the work that was done by Dr. Parsons and the group in Boston, showing that they can go up to 400, 500 mutations, and then the sensitivity of the assay can go all the way to 1 in 100,000 fragments. And they show that this type of approach can identify the tumor in the blood. But there is a bottleneck here. Some of the breast cancers, when we do whole exome sequencing, do not have enough mutations to develop an assay that has 500 mutations. So maybe we should, for some of the breast cancer, start looking at whole genome sequencing to identify more mutations and develop the assays that are as sensitive. This is an assay that is developed by Max Dean and Dr. Alizadeh at Stanford. It's a very smart approach. So we've been using these external UMIs or barcodes, and they said, okay, what if we just use unique molecular identifiers that are internal, meaning that we find sequences that are very unique to that fragment. And one of the approaches that they took is phase-seq, meaning that they looked at multiple mutations that are in the same, or 2 mutations that are in the same fragment. They're very close to each other, and there are somatic mutations. This is a very unique pattern. The chances of finding it by chance or because of sequencing noise is very small, and they show that this significantly improves the sensitivity of the assay and also decreases the amount of noise. Now this is being developed based on complex genomic alterations, indels, structural variants, so on and so forth. Bespoke whole genome genome approaches seems to be the most significant one. So this is the data published by Dr. Landau doing bespoke whole genome sequencing of the tumor, whole genome sequencing on the cell-free DNA, and relatively deeper sequencing of whole genome in the cell-free DNA. And they show that this type of approaches in the tumors can significantly improve the sensitivity of the assay up to 1 in 1 million fragment. More importantly, there is also a possibility of finding copy number alterations in cell-free DNA, knowing those structural copy number variations in the tumor. And this is something that they showed, and this has a lot of relevance for breast cancer. We know that a lot of the breast cancer are actually copy number driven. So in conclusion, there are multiple MRD assays that are being developed in this space. The sensitivity of these assays are significantly better than the current assays that we're using in metastatic setting. The targeted sequencing approaches, bespoke approaches, can achieve a sensitivity up to 1 in 10 minus 5, and whole genome sequencing approaches can go all the way to 10 minus 6, and also other approaches based on structural variants are being developed. The clinical data indicates that positive predictive value is extremely high. If the ctDNA is confidently positive, this patient will develop metastatic disease. But negative predictive value has not been established. This is not studied in large studies to know what is the value of negative predictive value, and we don't know what is the negative predictive value for serial testing versus one testing, and also different sensitivity of the assays. And also there is some evidence that multiple testing might be better in identifying the MRD. And also I think there is pressing need to, and this is something that we learned from this morning CTRAC triple negative study, that we need to understand the dynamics of these MRD positivity by breast cancer subtype, by risk category, per aggressiveness of the tumor, and also our pre-on post-adjuvant treatments that we're using for the patients. So what are the opportunities? So imagine that this is the continuous ctDNA analysis in the blood. So the patient received 3 cycles of chemotherapy. We know that after each cycle of chemotherapy, there is a spike because of the tumor kill. And this is a patient who nicely responded. She had MRD. She responded very nicely. This is a patient that is cured. This is a patient who had primary resistance, did not respond, and eventually developed metastatic disease. This is a patient who had early relapse, and this is a patient who had late relapse. This is a patient that the cells were to dormancy, or the cells were not replicating enough to be detected by the assay that we had, and at some point the tumor had late relapse. And I would like to highlight the delta between detection limit of the imaging and also detection limit of the ctDNA assay. The bigger this delta, the bigger the likelihood and the chances of intervening early and probably changing the trajectory of the disease. So it is important for us to, I think, to use an assay that has high sensitivity so that we avoid identifying overtly metastatic patients. But nevertheless, there are opportunities for escalation. So in each one of these approaches, we can escalate, and also at some point, we can start thinking about de-escalation in this setting. And I would just cover a couple of the clinical trial approaches that we can take, and you've heard about some of them. So this is the typical one, probably some of the early studies that we should design in this space, and some of them are ongoing. So we identify high-risk patients, we test them for liquid biopsy, ctDNA analysis, maybe multiple ctDNA analysis. If they are positive, then they will receive escalation of care versus standard of care. This can be our patients with triple-negative breast cancer who did not achieve a PAT-CR, receiving capecitabine versus escalation of care, and we look at disease-free survival and also ctDNA clearance. I would like to highlight this part of the diagram, that for the MRD negative patients, it's also important to include and follow these patients. We still do not know the negative predictive value of this test, and identifying these patients and following them, it is critical for us to establish this in the setting of the clinical trial. And something that we need to, as a group, work on is the question that, can we establish ctDNA clearance or molecular complete response as a meaningful surrogate of outcome? When we develop PAT-CR, we completely revolutionized the way that we develop drugs in early stage breast cancer. And for our disease, this is very significant. We have to wait years to have enough events. If we can establish molecular complete response as a way as an outcome, then we can significantly reduce the drug development and treatment development in early stage breast cancer. There are multiple studies ongoing in this space, and we saw some of the results, and we are looking forward to see more results and more studies in this space. And I would like to highlight that there are also ctDNA collected from multiple phase 3 clinical trials that is ongoing. And this is a pivotal study. This is IMvigor1010. This is adjuvant atezolizumab in urothelial cancer. It was a completely negative study. But when they did the post-hoc analysis and they looked at the ctDNA positivity and ctDNA negativity, you see that the atezo group in the ctDNA positive group actually was the one that benefited very significantly from the drug, and the ctDNA negative group was the one that didn't benefit. So we have multiple of these studies that we can start looking at the ctDNA status in these studies and then see if we can actually establish this as a biomarker. And also we start looking at including this type of ctDNA directed or adapted designs into as one of our outcomes in the design of the clinical trials. Another approach is in the low-risk patients for de-escalation. Maybe there is some opportunity for de-escalation for the patients who are low risk, the patients who were not sure that we wanted to escalate therapy for them or not. This can be patients who had PAT-CR, for example, and then if they are ctDNA positive, we can have escalation. If they are ctDNA negative, we can de-escalate, and then we can follow these patients. And then it is up to us at the end of the day to show that this type of escalation, de-escalation approach and this type of liquid biopsy guided therapy actually improves the overall survival for our patients. So we randomize the patients to standard of care versus escalation, de-escalation, liquid biopsy guided, and see if actually we improve the overall survival of the patients. And I would like to highlight there is also opportunity for drug development in early stage. So these are window studies. We are doing window studies now in neoadjuvant setting. We can actually have window studies in the adjuvant setting in the MRD positive patients. So if a patient has 100% risk of recurrence, it is a fair game to bring an experimental drug that we've been using in metastatic setting into the early stage setting to see if there is a signal in this space. And we can look at the ctDNA clearance for these patients. And the question here is that can we move the drug development and novel therapeutics to the early stage, not just develop them in advanced disease and then bring them early to the early stage setting. And then some aspirational clinical trial designs that we can think of. So this is a trial design that we go for after eradication of minimal residual disease. And there are some breast cancers that we have multiple good drugs. HER2-positive breast cancer, we have multiple good drugs in the HER2-positive breast cancers. So we can actually think of studies that, like platform studies, adaptive studies, that we give the patient drug X, then the patient receives it for few cycles. We know that molecular complete response achieved or not. If achieved, the patient continues. If not achieved, the patient receives another drug from the platform. And this can be an adaptive crossover design with the goal of achieving a molecular complete response in this setting, an approach that I would like to call no cancer cell left behind. And we think that in some breast cancers, there might be opportunities after we have the molecular complete response established as an outcome to think about this type of designs. So in conclusion, liquid biopsy assays have demonstrated potential utility across a range of applications, also in early stage setting. The current multi-cancer early detection ctDNA assays have relatively low sensitivity for breast cancer, cannot replace standard of care screening modalities, but there might be opportunities for high-risk patients that are at risk of second primaries and second non-breast cancer primaries to use such approaches. These bespoke MRD assays have shown very significant sensitivity and specificity. Across the board, there has been high positive predictive value. The negative predictive value, I would like to caution, that has not been established, and we do not know the dynamics in adjuvant setting. The number of mutations that we are tracking in this type of approach is important, and the amount of noise coming from the technical noise and also biological noise is important, and it affects the performance of the assay. Also, there are multiple other assays that are being developed, and we're looking forward to see these assays and results from these assays in breast cancer. And more importantly, there is pressing need. As a group, we start designing clinical trials and executing clinical trials, adaptive clinical trials, based on ctDNA to establish whether we can use them to improve the outcomes for our patients. So with that, I would like to acknowledge all of my collaborators at MSK and outside, and also our patients who help us know we have an active liquid biopsy program at MSK and translational program at breast cancer at MSK. So I would like to acknowledge all of our patients and families who participate in our studies and also all the funding sources. Thank you.